Hello, my name is Dr. Luan Nguyen. I'm an internist and I am a physician volunteer for MAVEN Project. Thank you all for joining us today and our friend Ankle Clinic Generations Family Health for hosting today's session. The talk title today is Assessing Common Motor Problems in Children with our speaker, Dr. Carter Wray. Dr. Carter Wray spent 12 years at Oregon Health and Science University as a pediatric neurologist, specializing in managing children with medically intractable epilepsy. He directed the pediatric neurology residency and was associate director of the pediatric developmental disabilities. So thank you, Dr. Wray, for sharing your expertise with us today.
Great to be with you. I'm going to dive right into assessing common motor problems, common being in quotations, because the true pathology is actually not that common, but I think often there's a question of how well is a child doing from a motor development perspective. Oops. So no disclosures. There's nothing in this that really mentions much of anything. I guess I very briefly talk about a couple of therapies. But there would be therapies that you would be referring patients to get, not therapies you would be administering yourselves. Accreditation, I think, as Dr. Nguyen talked about, you can get CME. And soon, I think the new platform is hopefully going to roll out where people can get CME for watching videos that have been recorded of our talks, rather than right now. I think it's all that you have to attend them live. But MAVEN will let you know more about that when it rolls out. So objectives, we're going to talk about sort of what is the developmental trajectory of a child. I think I was told that most of the folks on this talk do family medicine, so are seeing people across the age spectrum. Certainly, if any of you are pediatric specific, then this will be a little bit more of a review, but particularly talking about the knowledge of what kind of abnormalities in the physical exam would really make you worried about a child, in addition to just what you're hearing from the parents. And also knowing when to refer them. Kids sometimes benefit really predominantly from seeing a therapist, and we'll talk about the therapist role versus that of the physicians or nurse practitioners who might be specialists in various developmental problems. So the debility domains, really what I'm going to focus mostly on today is going to be gross motor problems. Gross motor problems would be the big muscles, things like sitting, standing, the sort of core muscles that help you locomote, as opposed to fine motor, which is, a lot of people think of fine motor as hands and fingers, and certainly there's an incredible amount of activity that's very specific that we need to learn to do with our hands and fingers, more so than the other bits of the extremities, whether that's feet or toes. Some people also use fine motor to talk about the control of the tongue and the lips, although on some levels we can think about the domains of development themselves, but then sometimes we also think about the domains as they interface with the specialists who might help with these problems. And so sometimes tongue and lips is seen separately. Also, the reality is that these are the four ability domains that you're going to look at in a young child. So in the first few months, because some of the other stuff will have to do with intelligence and cognition, and that can be really hard to ascertain until children are a couple of years old. And the reality also being that these domains interface with each other. So certainly intelligence or cognition will be very, very important for, does a child develop language? And to some extent, we use language as a proxy in the first few months of life for intelligence and cognition, even though they are to some extent separate. Certainly social interaction also has a lot to do with cognition. Fine motor will, as the lips and the mouth are able to move, can impact whether or not a child is able to make verbal or oral language. And certainly the biggest concern, I would say, is that children who are behind in multiple domains are much more worrisome than a child who's just having some problems making progress within one domain. So I certainly am going to talk a lot about gross motor problems, but the children who you should be worried about, do they need a referral? Do they need more testing? Are the kids who are behind in more ways than just one? as I think about development in general, we think that a neurotypical child gains an incredible amount of skills early on that sort of slows down as they get to be teenagers or 20 somethings, depending on when you really want to think about frontal myelination completing. The different developmental trajectories that we worry about, the most common word that I think a lot of people use for young children is delay. And so delay is the idea that a kid at some point in their life is not quite on the normal track, but the idea that they will then catch back up is to me very, very important in thinking about a child who has developmental delay. And in the first few months of life, delay is often the right word, but I think that we also need to be aware that some kids are not going to catch up. And so certainly children with disability have a difference from the normal curve that is not going to return to that normal neurotypical trajectory. And certainly if there's been a profound injury to the child's brain, that recognizing that as a disability and not just saying, oh, they're delayed, they're delayed, they're delayed. I've always chafed at hearing providers talk about the 20-year-old child with or adult with developmental delay. And I'm like, at 20 years old, this is not a delay, this is a disability. And realistically, we'll talk a little bit about science about why 5 years old is often a very good time to start switching to language. But some children who have known brain injury, it's very appropriate to say that the disability is present even sooner than 5. So while delay is a worrisome thing to a lot of you, I think the thing that really strikes a lot more fear into my heart as a neurologist would be the idea of regression. So a child who's really gained substantive skills and then loses a lot of them. And that is much more worrisome for a neurologic disease and not just the vagaries of development. And this is a regression curve where something got worse and yet they recovered. And there certainly are regressions where the child worsens to the point of passing away. And so this true neurodegeneration would be obviously the most feared thing. This all being said, I think that if you zoom in on any given child on a sort of day-to-day basis, neurotypical would actually involve a lot more ups and downs where kids may gain a bunch of skills, they may not gain them for a few days, they may gain a few words, and then they may have a reduction in their vocabulary, but that within a few days they then turn around and keep going back up. So I think that this timescale of little dips is not the same thing as a regression where major skills are being lost and not accessed for weeks or months. But development is definitely a much more complicated thing the closer you look at it. So when I was in training for the first 5 years of my 7-year residency, I was in Denver, and Denver definitely is a place that had a developmental group that came up with a screening tool of saying, when should kids learn to do what? And certainly if you look on this, there is an item where within this white bar, 75% of kids should start doing whatever skill it is. Once they get past the end of the gray bar, that's where you really would say this child is not meeting developmental progress. And some of you may have access to this as sort of a printed out thing. Some of you may have these questions embedded in your electronic medical record, where if you're having a child come for a 4-month-old visit, it may just pop up with, these are the questions you want to know. Is the child doing, again, from a social or language perspective, well, sorry, personal, social, fine motor, adaptive, language, and then gross motor. So these different domains, a child should be making progress across all of them. As I think about these steps, any one step that a child misses is not particularly crucial. It is certainly something where if we think about mobility as a set of skills that a child should be gaining, yes, between 2 and 4 months, they should do their first rolling from front to back. And then some kids immediately thereafter, some kids with a big bit of a gap will then start rolling from their back over onto their front. And then some kids will just start rolling sequentially because that's the way they get really comfortable with their rolling. And if their desire to be mobile is met by them rolling over and over and over so that they can get to the toy, they can get to the food, whatever they're interested on the ground, they may just skip the crawling phase. And many, many children don't crawl. In fact, some developmental trajectories don't even include crawling as a milestone because it's so often skipped. So to me, the idea that what the child wants is to move, And the first way they can move is to get off of their stomach, which is part of why we put them in tummy time, is because most of them hate tummy time, but they're motivated to get off of their tummy and onto their back. And then again, if they're able to move, eventually they will probably start to walk, but skipping, crawling is not a worrisome thing. And so missing that milestone is not as important as making sure the child's developmental need is being met. And so that is what is most important when I think about individual developmental steps. And again, not meeting multiple types of goals within a domain is certainly more worrisome. So the more problems you see, the more you should be worried. Individual things are much less problematic. And then certainly also, if you are not only missing goals within one domain, but if you're again missing multiple domains, that's more problematic. And we're going to talk quite a bit about how the clinical exam is super important, because if the clinical exam of the child is abnormal, in addition to them not meeting milestones, that's much more likely that the child has pathology that needs workup and assessment. So things that are involved in movement is a huge, huge, huge slew. I'm very brain focused just because I'm an epilepsy focused provider. So the cortex matters a lot to me, but there's also a lot in the central nervous system that's within the skull. There's the spine that comes out of the skull, and then there's the things that come off of the spine. So the peripheral nerves that carry signals from the central nervous system out to the muscles. There's the muscles themselves. There's the things that the muscle attaches to, the skeleton. There's also the energetics necessary for the muscles to do their job. There's the sensation part of the nervous system, letting the body know where it is in space. And then certainly there can be genetic conditions that can affect any part of this neuroaxis. So again, just sort of thinking about the neuroaxis visually, because I'm a visual person, I think of the central nervous system as the brain and spinal cord, so I circled those in purple. But there's also going to be the peripheral nervous system, and we have a bunch of peripheral nerves here that are yellow, but also thinking about the nerves connecting to the muscles and how that can be super important, and the connections thereof can be problematic. So the upper motor neurons, I'm going to do a tiny bit of pathology. I'm not super focused on pathology because in clinic, you're not usually thinking about pathology, but some of it does help inform how I think about how the brain gets out to the muscles to make the whole body do its moving thing. So the upper motor neurons are going to be coming from the brain and going down to the spinal cord, where they then transition to meet the lower motor neurons. So the spinal cord is where we have our area of overlap. You're going to get different problems and different manifestations depending on where there is dysfunction. So in general, the up is the up and the down is the down. So the upper motor neuron is the upper part because that's where the brain is. And kids with problems with their brain and to some extent spinal cord will tend to have increased tone and increased reflexes. And we'll talk about those in just a second. Whereas lower motor neuron problems will tend to cause decreased tone and decreased reflexes. Another slide where I don't want you to get down in the nitty gritty, but the idea that motor problems, as I mentioned, a lot of them come from the brain. So the big Venn diagram circle is brain stuff, whereas there's lots of stuff that's not brain as well. But within brain, there's going to be questions of, does it cause problems? And so the fundamental problems are more the diseases as opposed to stuff that's true just delay of kids not catching up to where they should be is often a little bit fuzzy. And the things we're going to worry more about are things like cerebral palsy. So this is a non-progressive set of diseases that are permanent dysfunction of motor function that's due to brain stuff. There can also be stuff that is not cerebral palsy, and that is particularly the stuff we worry about that's genetic or tumors. So progressive stuff, obviously, we'll be worried about a lot differently than the static stuff. So motor assessment. So motor assessment, most people do jump to muscle strength. And I always try and say, wait, there's more to motor than just strength, because strength is very obvious. But tone is something that you hopefully already have some feel for, because it's something you really need to actually hold the muscles in your hand and try and move them passively to see how much resting tension is there. And so tone can be high and tone can be low. So hypertonic and lower is hypotonic. Then there can be a mixture where children have both high and low tone that we call dystonia. Spasticity generally goes along with hypertonia. Nitpickers would say that it has to do with the velocity-dependent stretch and the contraction thereof. But in general, spasticity is going to go with the high tone. But the important thing with this is it's resting. And so if the child is not resting, if the child is not calm, then you can't really feel tone, because if the child is fighting you, which most fussy babies will be fighting you, what you're really then feeling is strength. So if the child is actively moving against you, you can't really talk about tone. And so that's a tricky thing that I, as a more seizure facing doctor, was less comfortable, and still am less comfortable, than my sort of neuromuscular colleagues who are really, really good at tone. But a lot of the time, you just have to be patient to get a feel for what is the child's resting muscle tension like. As I mentioned, strength is active force generated by the muscles. And in adults, you can say, well, is it 5 out of 5 strength? And that is something that is wonderful for our compliant teenagers. You could sometimes get a sort of precociously developmentally awesome child who's 5 who might give you muscle force in a requested challenged way, but really most of motor in young children is going to be observing what can they do, asking them to do things that require a lot of strength, like standing up, doing squats. Those are great ways to see, is a child strong or not. But saying, can you push against me, is just not likely to work real well until, like I said, you're talking about middle childhood. The least thought about of what I consider the 3 core things in a motor assessment would be the bulk of the muscle. And certainly if the bulk has reduced, that's a sign that whatever motor problem is very, very long standing, that you don't lose muscle bulk over a few days or a few weeks. It really takes weeks to months to lose muscle. And then, as with many things in the human exam, symmetry is key. So tone or strength that are different on one side of the body from the other is much, much, much more worrisome than symmetric things, because symmetric things may just be how that child is born. There's some great videos that the folks in Nebraska and Salt Lake City, it's hosted out of the University of Utah, have a motor assessments of newborns. They have some videos of 3, 6, 12 months, which I think is really where you get a lot of the differentiation of what should a child be able to do. And so I really like these videos, like I said, particularly the young months, and then 18 months as well as 2.5 years. So I'm going to show a couple of these as I think about some cases. So case 1 is a 3-week-old baby. And just focusing on your normal questions that you would ask of any 3-week-old, are they meeting their needs for fluids? Because if they're not peeing enough, then you worry that, hey, that's a child that is either sick or something is wrong if they're not able to stay hydrated. Certainly, are they feeding well? And so far as a safety perspective, is the child capable of swallowing safely? If they can't, they may be aspirating or putting food into their lungs. So coughing, gagging, spitting the food back up. And then certainly if they're not meeting their needs, whether it's hydration or swallowing enough food, are they gaining weight appropriately? Let me see if I can.
Look at ventral suspension. We're going to bring the baby over on his tummy.
And so this baby is hanging too floppily. So the head is too far down. They're not raising, particularly for a 3-week-old, should be able to have the head up for more of the exam than what they're doing. And this child sort of draped almost like a wet rag. It's doing a little bit of extension, but not as much as I would like.
Usually, typical baby wants to be more flexion of extremities and a little bit more extension of the hip and of the head.
So that's what I would say. This would be a baby I would be worried about their tone not being right, and why their tone and to some extent strength is not right is going to be something to dive into. And I just want to contrast. So that was a 3-week-old, and then this video, they have a wonderful. So they have a section for the newborn of the normal versus the abnormal. So that was a baby who is not quite right, particularly for 3 weeks. Oops, just skip.
Ventral suspension.
Okay, so this is the healthy baby. So this is a 5-day-old, and see how the head is more in line with the back. So this is much more normal. Head control. This is the child showing the legs much more flexed, pulling them up, waving the arms around, much more spontaneous movement. So lots of just normal baby wiggles that the more babies you get to see, A, the luckier you are, but B, the more you can build up your normative database of like, hey, is this child normal or not? And so this is not a super frog-legged out, ultra hypotonic baby, but this is definitely a baby who is not quite right, and we want to figure out why. So certainly tone and strength are most problematic if the child is not feeding well. So as I mentioned, if they're not making 3-4 wet diapers a day, then obviously that is something I would think about sending the child to an emergency room to make sure that there is some addressing of why is the child not hydrated, and making sure that they're getting seen very promptly. With the swallowing safety problems, the question is how much are they aspirating? If they're causing persistent respiratory problems, that's also something where you'd probably want to get them into a hospital. But if it's minor, you might start by doing an outpatient assessment. And then weight gain could be a lot of things insofar as why are they not meeting their caloric needs. So I think that the most sort of testing important question I would ask in a child who's showing up for their first exam at 2 weeks would be, have they gotten their newborn screen? Because Connecticut, I believe, is just a 1-screen state. In other states, there are 2 newborn screens, one done at 2 days of life, and then one done between a week and 2 weeks of life. And the reason we want to do the newborn screens is that the treatable conditions are very frequently on there. And so I think that the worries we have for like what is going on with a child who's got low tone or not strong or having weakness is that something you can fix. And certainly something like Down syndrome is not something you can fix. They're going to have tone and strength problems, well, tone problems in particular, throughout their life. But the treatable things like hypothyroid, congenital hypothyroidism is something that absolutely needs to be treated as soon as humanly possible. Things like inborn errors of metabolism where the child can't make energy from the food they're trying to eat. Those are things that often show up on the newborn screens. I think this is most commonly missed when children are born at home, although certainly many birth midwives will try and get them from home to births. But I think A, making sure that all of your children have got them, and B, that they've been resulted is really important, because there's an incredibly large set of things that you want to not miss. But yes, I think home births are the thing that I worry about the most. So again, newborn screens really focus on diseases with major interventions, things that can fundamentally change the basic trajectory of this child's life. Like I said, 2-day-old is the common. Children born in the hospital tend to get it on the way out the door. And like I mentioned, some states do a second, and that can be important for how they threshold what are the abnormalities. If there's an abnormality, you as the PCP should be contacted by the state agency. And it's important to remember that the screens are screens. So screen does not mean a diagnostic test. So when I think about how they're done, if you get values that are all over the map on this axis for whatever this is, so this could be T4 for if you're looking at thyroid, and we'll talk about some other conditions. The state has to decide how are they going to use a cutoff, because you could put the cutoff here where you miss a kid who has a disease, and yet you only have one false positive. So this kid here would be triggered as saying, oh, this is abnormal, even though this is a normal child, and this is just part of the natural variability of the value for this disease state. You could also threshold it so that you get no false positives. So all of the kids who are healthy do not show up as being flagged, but you're missing 2 kids with disease. And you could try and set it so that all kids with disease show up, and you just end up with a lot more false positives. And depending on the disease state, sometimes this is easier to get the right kids in and keep the kids who are normal out. But there are a lot of variables depending on how old the child is, how maturationally mature are their enzymes. And so it can be really hard to have a perfect screen. And I guess the reality is none of the screens are perfect. They will all miss some children. More often though, when you get a value, it may actually not be true disease, in which case you need to do confirmatory testing, which may just be repeating the exact same test that they had at 2 days of life. But you certainly want to confirm, is this actually a disease? If the confirmatory testing is positive, then they'll need to be referred to the specialist that helps manage that. And then for most of these diseases being genetically based, they're going to need somebody who can help with the what does this mean for the family. So the Connecticut newborn screen is actually more robust than a lot of states, and 60, I think most states have at least 30 on theirs. But making sure that the newborn screen has been done, and that some states make it really easy to see that the results ideally are normal. But there can be technical problems with the collection. So even if the parents say, oh yeah, my baby got the heel poke test, did it actually get to the state agency that did it? And are they able to actually do the tests is super important. So jumping to the exam, reflexes, most people use a scale from 0, meaning no reflex, to 4, meaning very, very high. There certainly are certain hospitals like Mayo Clinic in Rochester, Minnesota, that like to come up with their own scales. But I'm going to stick to the 0 to 4 because that's what most people in the US and I believe around the world like to do. So high reflexes would be 3s and 4s. Normal, most people use the number just saying 2. And then low reflexes could be 1. And if there's no reflex at all, we would call that 0. So I think it's really important to use some visuals of this. So this video is going to show us somebody who has high reflexes due to serotonin syndrome, which isn't particularly important. But the idea that you barely have to tap and you're getting a really robust jerk out of that knee. So that is too much reflex. This is looking for clonus by just jerking the foot back towards the body. And I would call this sustained clonus because the clonic beats are just rhythmically happening until the examiner takes his hands away. Having up to certainly 5 or so beats of clonus is actually quite normal in brand newborns. Even up till 5 months of age, you can have clonus in the ankles that is normal. And so that is not particularly worrisome, but it should go away again by the time the kid is 6 months. But again, 10 beats at 5 months would certainly worry me, whereas 2 or 3 beats in a brand new newborn would not worry me at all, as long as it's symmetric. On the low end of the reflex spectrum, I certainly think the big question is the reflex truly absent, or did you just not get it? And this is not to besmirch anyone, because I have certainly not been able to get reflexes in some children. Really, as I say at the top, like with tone, you need relaxation. And there are children who will not relax, in which case getting reflexes can be quite problematic. So I think that the problem can be certainly patient-driven, but it can certainly be user error, where sometimes I have not been able to hit a tendon well, and therefore I haven't gotten it. So I've definitely gone to emergency rooms where they've said, this child is areflexic, and I walk in and I just hit them and I'm like, nope, they're not areflexic. There it is. But my neuromuscular specialists colleagues have also been able to walk into a room where I was like, is this a little low? And they're like, boop, nope, you just didn't get it right. And that's because for specializing in nerves and muscles, you really put a tremendous amount of emphasis on whether or not the reflexes work, because it tells you a lot about where the reflex arc is insofar as what are the nerves getting to the spine, and is the spine kicking out its reflex contraction. So again, we're going to think a little bit about the reflex arc from a top-down perspective. So the central nervous system plays a very important role in the reflex arc, and particularly that the brain inhibits the reflex arc. So if we think of the purple being the message down from the brain, it's saying, hey, let's keep this calm, let's keep things low. So the inhibitory signal should be kicking out from the brain all the time. Whereas the peripheral nervous system is down below. It includes both the muscle contraction arm of the reflex, as well as the sensation loop that will bring things to the spine. So if there's a problem with the upper motor neuron, it's going to be different from the lower motor neuron. So the inhibitory signal, if it's interrupted, then you're not telling things stay calm, stay calm, stay calm. And this loop will be very hyperexcitable. So you're going to get increased tone because the lack of inhibition from the brain is not going to calm the muscles down. And particularly the reflex, when you hit with your little reflex hammer, the patella tendon gets stretched. It sends a message to the spine. The spine's inhibition is not being provided by the upper motor neuron. And so the brain signal being absent will cause this loop to be more active. So that is where the exam from the last video showed more reflex, because there's not inhibition from the central nervous system. On the other hand, if we don't have any problems, we're getting normal inhibition from above, but now we have blockage either from the sensory neuron bending back or from the nerve sending muscle messages saying, please contract. If the spine can't send a message to the muscles will not contract at baseline. So our tone will be low. And more importantly, for the reflex arc, we won't be able to jerk when you hit with the hammer, you hit the patella. This signal loop won't happen because there is a problem with the lower motor neuron system. And so you're going to have hyporeflexia or decreased or even absent reflexes. So again, things from up top are going to cause things to be up, the tone and the reflexes, and things that are problematic down low will cause both the tone and the reflexes to be low. So here's a case. So here's an 8-month-old girl. Everything went fine with delivery. The parents are saying, oh, she's a lefty just like we are. As a brain doctor, I don't like handedness early. And by early, I certainly think in general that any handedness that is obligate before a year of age is almost by definition pathologic. Really, kids shouldn't be handed until they're probably 2, and many kids aren't really handed until they learn to write in kindergarten. So I certainly think that looking at these 2 pictures, I'm seeing something different about their reach. And so if you restrain the child's hand, they say she's a lefty, I would always encourage you to try and restrain what they say is the good hand, and then see what the other hand does. So if the right hand doesn't pick up and start grabbing at the world, because babies like to grab things, certainly by 8 months, she should be grabbing well. On your exam, you think that the right knee reflex might be more brisk. And again, tone can be super hard in a fussy baby, so she's not doing it. So I guess the question, if people are willing to do into, I guess you could do it into the chat, or you can do it into the Q&A. No, I guess this is a chat thing. So throw into the chat, which one seems better insofar as the reach from the left hand or the reach from the right hand? More advanced on the left, more advanced on the right. Any votes in the chat? Yes, left is better. I'm seeing that, and that's great. So the left is getting really close to what we'd call a pincer grasp. So pincer grasp itself would involve just the index finger and the thumb, whereas this is more, not even a full-on raking grasp. So this is technically the radial digital grasp. You don't need to worry about that, but certainly the idea that as a child gets older, they should be able to reach better with just the fingers and the thumb, as opposed to the primitives, or not even a full-on palmar grasp or a raking type of motion. So why would a kid use the left hand well and not their right hand well? And it's not in this case because their parents are left-handed. Although being lefty is genetic. So if you have a baby whose parents both are lefty, the kid will probably be lefty, or at least ambidextrous. So what this child probably has is cerebral palsy. And so cerebral palsy, while being really, really frightening as a term, really is just defined as brain-based weakness that is non-progressive, happens in the first year of life. So the fact that it's developing, so in the child's first year, to some extent is really arbitrary, but it is just the way we've decided to define cerebral palsy, as opposed to if a child had a brain injury at 1 year and 1 month old, that would be a different kind of motor disability. But a lot of this is going to happen when the child is in utero, and certainly the manifestations of the cerebral palsy may be very different as a child gets older, as either other muscles get stronger or as the expectations for the child's strength are more obvious. But the weakness itself should not get worse. And certainly if you have a child who you think has cerebral palsy, they should be followed by a specialist who can help you with saying, like, hey, is this getting worse, or is this just the trajectory of somebody who's had non-progressive weakness their whole life? We can define cerebral palsy in a bunch of different ways, and certainly the type of weakness is often referred to spastic. Cerebral palsy is the most common, so this is between 50 and 70%, depending on who you want to talk to about it. So spastic cerebral palsy is where the brain-based weakness causes upper motor neuron-based stuff. And so by the sort of truism I was showing you before, that most of the time, if there's problems with the upper motor neuron, the tone is going to be up, and so those kids will be spastic. There are kids who have specific hypotonic or low tone cerebral palsy, and that's more commonly due to things like Down syndrome, where the brain is just not sending out quite the right signals all the time. And then there's the sort of grab bag of dystonic, would be a mixture of high and low tone. And so that on some levels is at least as common as hypotonic, but I certainly think the majority of kids are going to have spastic cerebral palsy. And then things like ataxia, where they just have coordination difficulties, certainly happens more when you have things like isolated basal ganglia deficits. And then chorioathetoid is a wonderful amalgamation of words, where if you show a video of a child moving with motor impersistence or writhing things, one movement specialist may say, that's chorea, and then show it to another one and they say, it's athetosis. And then you get another third person and he says, well, no, it's definitely chorioathetoid. And the reality is there's the complex movements, and I don't think you have to get super, super worried about this within the cerebral palsy spectrum. It can also be defined based on where it is. And so diplegic cerebral palsy would be more common with weakness that affects the legs and the lower body more than the upper body. Certainly this child, I'm worried about hemiplegia because she's not using her right hand well. Given that she's only 8 months old, you don't really expect that much out of her legs. So it may be tricky to say how impacted are her legs. And then quadriplegia is where the whole body is being affected. There is also tetraplegia where one arm more commonly is better than the two legs or the other arm. But yeah, so quadriplegia versus hemiplegia would be the two most common distributions of weakness that we think about. And then we can say, how severe is it? So by definition, if it's cerebral palsy, it has to limit their function to some extent. But there is very mild cerebral palsy where really it's mostly detected by people like doctors and physical therapists, and certainly kids who have had minor hiccups in their delivery process or in their neonatal intensive care unit stay. They may end up with really mild CP where other people just don't know because they're able to walk without restrictions. They don't need assistive devices. They don't need things like ankle-foot orthoses. And so those kids are doing great. And we love the fact that there is mild CP, but there certainly can be motor problems there. So level 2 would be the kids who can walk independently, but maybe the kid needs the banister to get up the stairs as opposed to being able to walk up the stairs with something in their hand. They may need ankle-foot orthoses for specific reasons, like to prevent their tendons from getting too tight, but they're actually able to walk without them. The kids who need assistive devices, so the kids who need crutches, the kids who need braces, or can power themselves in manual wheelchairs, that's where we would call it level 3. So level 3 is obviously much more significant, but really the kids who are truly non-ambulatory would be the 4s and the 5s. So the kid who requires a walker to walk, the kid who can only power his manual wheelchair, whereas I think the wheelchair inclusion in level 3 is actually meant for more the kids who are able to walk decent distances, but for very long distances, the wheelchair may be more appropriate. And then level 5 would be the kids who can't push their own wheelchair, the kids who might need either a mechanical wheelchair if they're able to operate that, a motorized wheelchair if they're able to operate a motorized one, or the kids who need their wheelchair pushed. So the spectrum of cerebral palsy, when you say it to people, most parents are going to be very, very scared because they're going to be thinking about this, the kids who are in wheelchairs. And the reality is there's lots of kids with cerebral palsy who walk on their own. So this is a picture of this child's brain. And so radiologists, for some reason, always like to put the left side of the brain on the right side of the picture. That's just the way the convention is. So this brightly lit up part of the brain has all been injured by a stroke in utero, but the left part of the brain controlling her right body. And this is certainly what I worry about when I hear of kids who are obligately handed before a year of age. So this is a huge stroke. This is the middle cerebral artery territory. So the anterior cerebral artery would perfuse up there and the posterior would do back there. This kind of stroke in an adult would be devastating. This would cause a patient to not walk. This would cause a patient, if it's their language dominant hemisphere, to not be able to talk, aphasia, all kinds of badness. But kids do great. Well, yes, a kid with this degree of injury, by definition, will have cerebral palsy. It could still be type 1. She's got a 90% chance of walking. So most likely a type 1 or type 2. Very, very unlikely if it's middle cerebral artery territory alone while in the nursery, that it happens during the perinatal period that she will be non-ambulatory. Many of these kids, like this child, look great when they're born because if the stroke happens enough weeks before delivery, they've already compensated and they come out looking like symmetric, nice, normal babies. This shows, though, that if she's going to learn to walk, she's probably going to learn it fairly soon. So the vast majority of kids who end up being non-ambulatory, so the level 4s and 5s, are really off the mark by the time they're 2 or 3. Kids like this baby will keep making tons of progress. They will likely start showing that they're not making all their progress by age 5. And so this is where I've mentioned that I prefer to use the term disability certainly in a kid, even where you don't know what the cause is, if the problem has been present since birth and they're 5 years old, they're probably not going to normalize. They've made 90% of their progress. So yes, they can continue to get better, but they're not going to go from non-ambulatory to ambulatory if they're 5 years old, not walking. So revisiting case 2. So by birth history, I'm worried that she's pathologically left-handed because her right side is weak. That is why she is not doing a good reach with that right hand. The reflex on her right side is high. That's consistent with a brain injury on her left brain. And then the hand being more affected than the leg is a little bit tricky to say because she's an 8-month-old and they don't do that much with their legs other than sort of kick. They're not standing. So it's hard to tell. So the fact that she had delivery with no complications, the stroke certainly could have happened before she was born in, like I said, a huge territory of the brain, but she could just look fabulous. So neuroplasticity is something that makes me happy as a human being to know that babies can reorganize much more completely than we can as adults. So her tone, again, is likely high. The tone, even though you couldn't get it if she's fussy, just common things being common, she is likely going to have spastic because it's high tone, hemiplegic because it's going to affect one side of her body, cerebral palsy. So again, we can't give her a GM-FCS yet because she's likely to be either a 1 or a 2. So again, this baby is likely to do really well. Yes, you want to get them into services, which we'll talk about more in a little bit. But the brain of a baby just does so much better than the brain of us big folks. So while I think that it's important to own that this is a very scary diagnosis to have, it is very often appropriate, and it really is just describing the weakness itself, brain-based weakness, cerebral brain palsy weakness. Many kids with cerebral palsy do have other brain-based problems, and I think that when I was in residency, a lot of people would use the word mental retardation, tying it with CP, saying, oh, this child's got MRCP, and the reality of that is that if a child has very profound motor limitation, it can be really hard to assess what their cognitive abilities are. And so I certainly think that while, yes, many children will have cognitive impairment is the new preferred term over mental retardation, the cognitive disability can be hard to tell. And for those of you who haven't seen the movie Out of My Mind, I think it's a wonderful depiction of an actor who has cerebral palsy, depicting a character who has even more severe cerebral palsy. And so it also was a great book. But she's given a cognitive assessment with a cherry, a strawberry, a red balloon, and a banana. And she's asked, well, which of those four doesn't fit the other? And she's like, well, is it the yellow thing because the banana's yellow? Or is it the thing that's not a fruit because 3 of them are fruits? And so I think that it is emblematic of the complex difficulty of making assessments in cognition in a child who has profound motor disability. And again, cerebral palsy is the right word for kids who have it, but if the disease is progressive, then it's not the right one. I would say that the majority of children with cerebral palsy will have abnormality on an MRI that shows this is how my brain is injured. And then there's the kids who have genetic stuff that we can find. But then there's also stuff that's genetic stuff that we can't find. But I think that whether or not the unknown cause of cerebral palsy is a progressive disorder is something that, again, the children should be followed by specialists who should keep questioning, hey, why is this kid the way he or she is? So here's a different kid, a 3-year-old boy whose mom says he's just not running like the other kids in preschool. And that is certainly something that lots of parents can be worried about. Is it my kid like the other kids? Kid was not super on time for walking, but not worrisome. I mean, lots of kids don't walk until they're 16 months, but also there's a little bit of speech stuff that makes you wonder, is there maybe more here than just the motor exam? So on your exam, his muscle tone throughout his body is low. But weirdly, because usually tight heel cords or Achilles tendons, usually that goes along with upper motor neuron stuff. So you're like, this seems like a disconnect. The muscles seem a little floppy, a little squishy, but the tendons are tight. So why is that going on? Also, if you get really nitty gritty, this picture shows the calves of this child, and the calves are bigger proportional to the other leg muscles. And the calves even feel more squishy than the rest of the body, where the bulk of the muscles is normal. The walking gait of the child is more waddling. And when you ask the child to run, both feet do not get off the ground at the same time. And so that is not running. So that is important to say, wow, that's fast walking. That's more than a normal speed of a gait, but running by developmental definition, both feet have to get off the ground at the same time for us to consider that a true run. Here are some pictures of the child trying to stand up. And so you really, like I said, with the young kids, having them show you stuff like, hey, can you get off the floor? Having the kid lie down. Okay, he rolls over, getting the arms out, using his arms to get his body up, producing a pretty wide base right here, and then being able to only get to standing by pushing off with the leg. So that is a very abnormal way for a child to get off the ground. But again, you're not going to say, hey, show me how strong your muscles are. You're going to show me, how do you walk? How do you run? But getting kids off to stand themselves off the ground is a really important thing to do. So the reason this kid has this problem is a muscular dystrophy. Dystrophy meaning dys or abnormal, trophic meaning growth. So the muscles in this whole set of conditions are not growing normally. Whether you're a lumper or a splitter, you can certainly say there are more types of muscular dystrophy than you can shake a stick at, but certainly there's a large number of conditions. And the problem with these is the muscles will get progressively weaker. The muscles will break down over time. And so in the different muscular dystrophies, different muscles are going to have more problems. How weak those muscles are could be different from disease to disease. How quickly they deteriorate, and then when the symptoms declare themselves is going to be different in the different muscular dystrophies. A lot of people, when they hear muscular dystrophy, they just jump to a group of diseases that have to do with the protein dystrophin. So dystrophin is a very important anchoring protein that helps helps transfer the muscle contraction to the whole fiber. And so if you don't have good dystrophin, then you can't transfer the power and the muscles don't do their job right. The more severe of the two dystrophinopathies, as us fancy doctor types like to use, is Duchenne's. I don't like using dead white people's names for disease states, but certainly there is a much more severe phenotype. This affects boys usually by the age of 4. You can tell that they're abnormal. The milder forms historically been called Becker, but they're different only in how is the dystrophin protein affected. Dystrophin is on the X chromosome, so the profoundly affected are all going to be boys. There is a female phenotype, so sometimes the carrier moms and or the sister siblings can be affected. And for the girls, it's usually more often cognition because there is dystrophin in the brain as well as dystrophin elsewhere. So certainly the severe dystrophinopathies, the most common, like I said, will be the dystrophin based, whereas the other muscular dystrophies can be the things like the affect the fascia, the scapular muscles, the humeral or arm muscles. So there are lots of other ones, but you don't need to be super worried about it. But I certainly think if you have a kid whose tone is low and they are weak, this is actually a video showing the Gower sign. So this child is going to be asked to stand up. He's a little bit better than the other kid, but also propping with his arms, pushing the legs out to a wide base, and then only briefly tapping off with one hand, but certainly you shouldn't need to push up with your hand to get yourself vertical. So one of my mentors taught me if there's motor delay, check CK. So creatinine kinase is unfortunately also called creatinine phosphokinase by some people. And there are different creatinine kinase isoforms. You don't need to check them, but just for those of you who trained even before I did, before there were troponins, we would check creatinine kinase isotypes to say that the MM form was the skeletal muscle versus the MB would be the form you would see in a heart attack. And then the brain-based CK would be the BB form. You don't need to worry about this. Just check a CK. If a child has something that you're really worried their muscles aren't right, muscular dystrophies, they're usually very high in some of them. So the severe dystrophinopathies will be many thousands, whereas the upper limit of normal is 200. So certainly if the CK is elevated, you are likely dealing with a disease that has affected the muscles. And if it's been a chronic thing, then it's more likely to be in the muscular dystrophy. Sure, you might think about this in adults getting things like rhabdomyolysis, but that's pretty uncommon in children. So an elevated CK should certainly both make you think refer now and also should make the referral go through quicker, because I would imagine that Connecticut has somewhere near the national average of a 6-month wait to see a neurologist. The lack of elevation in CK does not rule out muscle disease, but again, it's certainly something I think is a very quick check that should be done, and in fact may be done soon in Connecticut on all babies, as we'll talk about in a second. So definitely don't want you to worry about all the different hereditary neuromuscular problems, but certainly, like we said, 200 is the upper limit of normal. For the majority of inherited neuromuscular problems that involve the muscle, that CK will be high. And Duchenne, being the severe end, will, like I said, often be in the 10,000 range. But there are some diseases like fascioscapulohumeral muscular dystrophy where the CK will be actually normal. So dystrophinopathy historically has been treated with steroids to sort of mitigate the inflammatory cascade that causes the muscle to break down. There are now genetic treatments. They're not cures, but there's several ways to try and compensate either for if the child has a point mutation or point deletion to skip over the part of the genetic problem that will allow them to create a more normal dystrophin protein. There is also a genetic therapy that tries to get them to express an amalgamated, they call it a microdystrophin, but they've trademarked that, which I hate. But a smaller dystrophin that has some of the domains. It got approved just a few years ago. It was put on hold earlier this year. I think they've resumed using it here in the US. The Europeans, however, did not allow it to be used. There are some questions about the adeno-associated virus. So basically, you have to put the gene inside of a virus and then infect the tissue with the quote unquote good gene to get the child to express the better genetic information. I think the Europeans have questions both about the vector and is it safe, or is this whole therapy not sufficiently helpful enough? Does it lead to enough quality improved life years or qualities or something that the Europeans have a more stringent threshold of making sure that therapies lead to a more robust improvement to generate enough value or return on the multi-million-dollar treatments that these unfortunately all are. So if you have a kid who has a dystrophinopathy, they really need to be seen at a neuromuscular center. They may even want to shop around, because I was aware that Seattle Children's Hospital, despite being a much bigger hospital and having a bigger catchment area than what we have here at Oregon Health Sciences, was actually doing half the number of genetic treatments for kids with dystrophinopathies total. So not just half per capita, but half total. So I don't know what the East Coast competition is between the different hospitals as to who is doing which gene therapies. But certainly if you have a kid with Duchenne's or Becker, they should be in with the clinic that can talk with them about this. Dystrophinopathy may be showing up on your newborn screen soon. So the only two states that have it, Rochester, Minnesota, having a strong neuromuscular clinic, and then a couple of the Ohio hospitals had parent groups that really pushed for, we wanted Duchenne. Basically, they wanted a CK to be added to the newborn screen. So checking creatinine kinase is already started in these two states. We have a couple others who've said that they're going to, but haven't actually started the screening. But you guys in Connecticut, like us in Oregon, have the state discussing whether or not they should add CK to the newborn screen to try and pick these kids up. But right now it's not, and certainly it will be a 5-year lag even after they start the testing, because like I said, many of the kids don't declare until they're about 4 or 5 years old. Here's another kid. She's 4 months old, and the mom says she's not holding her head up as well as she used to. And that certainly should make you worry about regression. Poor head control with diffuse hypotonia and absent reflexes. If she's got really good eye contact, that makes me think that her brain is doing well. And I'm realizing that I'm a little bit short on time, so I'm not going to get too much into the weeds of spinal muscular atrophy. This fortunately now is on the newborn screen for Connecticut, so hopefully you should not actually see kids, although some will be missed. So I'm going to skip over that. The other thing you could worry about would be infant botulism. But given the time, I want to save some for questions. So resources, getting kids into early intervention is usually your best first step. Some of it is eligibility based on income, but certainly the severity should affect whether or not kids should get early interventions. Up until 3 years, it should be separate from the schools, whereas 3 to 6 years should be in school. So the assessment that you can ask for through an early intervention assessment will involve a bunch of therapists doing a bunch of assessments. And I certainly think that here's the link to your up to 3-year-old thing. Once they're older, they will, like I said, be seen through the school system, and they can get either an individualized education plan or an IEP, or a 504 would be a plan based on a medical diagnosis. The MDA clinics are great. They support specifically things that are going to have low muscle tone because they're either from the spine or they're for out. You have 2 muscular dystrophy clinics in Connecticut, and there's a third one that I think just services adults. So again, the kids with muscular dystrophy should have low tone, low reflexes, and some of them will have normal reflexes initially. Shriners Hospital is another group that has historically offered free healthcare. They've switched over after 2009. They started doing insurance as well. The Shriners are really great. You don't have any in Connecticut proper, but just north of you in Springfield, they have a Shriners that does treat cerebral palsy. The Boston one, I think, is part of the whole fiasco of how many different Boston hospitals are all trying to chase each other to do all the different things. And then some Shriners host muscular dystrophy clinics. So who to refer to? I certainly think if you have gross motor problems, physical therapists are the best first place to start. They should be able to get the kids in faster. If you're more worried about fine motor, occupational therapists tend to focus on that. There are different physician types that manage children with developmental problems, and a lot of this really depends on who's available and who can see things quickly. Sending kids to a comprehensive clinic can be wonderful. That way they see either a physician or nurse practitioner as well as all the different therapists. But the wait for these is usually at least 6 months. And for the kids who are over a year age, it's often multiple years. So I think that it is important to try and work with those clinics, ideally getting around the wait list by referring just to the physical therapist at this multi-practitioner group. And if that physical therapist has worries, hopefully they can streamline them in to get to see the physician more quickly so you can get a diagnosis sooner rather than later. So in summary, how concerned you should be depends on how many milestones a child is missing, and particularly what the exam is like. Thinking about how strong is the kid, but also what their tone and bulk is. The reflexes usually should mimic the tone. If the tone is high, the reflexes should be high. The word delay is great if you think the kid's going to catch up, but certainly if it's longer than that, disability is the right word. Like I said, cerebral palsy is scary, but it is accurate in many children's case. And with that, I will take questions. If there are any questions.
Wonderful, Dr. Wray. Very comprehensive and very complex discussion. Are there any questions that you would like to ask?
I think I may have gone on too long. Sorry. I'm not as familiar with this topic as I am with seizures, so I went on a bit. For those of you looking for more information, I'm going to give another talk next week on seizures in kids. Although the seizures are pretty applicable to adults. There's an infantile spasms lecture I just gave that, like I said, should soon be available for CME through the website. And then if you want different topics, we've had a talk that MAVEN gives on headaches in kids, which scares lots of folks. And then there's some more neurocognitive stuff that Wendy Silver gives that she's happy to do as well.
Okay, great. There are a couple of comments, so thank you for your outstanding talk. Before you take off, I just want to remind you about the CME survey. Please, when you check out the webinar, there will be a link for you to fill out the survey. When you do the survey, not only you get the CME, but it also helps us plan the best session for you in the future. We share the information that the feedback that you get to our speakers anonymously, and they appreciate your thoughts. For educational sessions, we hope you enjoyed the sessions today. And if you're interested in attending the future sessions, all clinics can also anchor do education session like today, which means you get to pick the topic, the date and time. And the only requirement is that you or someone from your clinic attends a session. And if you're interested, please contact Kristen, ktalbot@mavenproject.org. Just so you know, we have MAVEN Project offers mentoring to all our community providers at any point in your career. Some topic ideas for reference, such as new practice provider, excuse me, challenging cases review, preventing burnout, building teams, executive coaching. And we also offer specific mentoring like EKGs, GCM. So feel free to reach out to us through the portal or to Kristen Talbot. Hopefully you enjoyed the sessions today, and we will get the slides sent out to you, slide deck sent out to you by Zoom. And thank you for joining. Thank you, Dr. Wray, for this discussion.
Absolutely. And Joseph, I certainly think behavioral head banging, if it's bad enough to cause the brain injury, like there's going to be a lot more behavioral stuff you want to worry about than just the injury to the brain.
Thank you.